Today we're speaking with Dr. Stephen Patierno, Executive Director of the George Washington University Cancer Institute and Vivian Gill Distinguished Professor of Oncology. He is also Director of the Molecular and Cellular Oncology Program, Professor of Pharmacology, Genetics, and Urology in the School of Medicine and Health Science, and Professor of Environmental and Occupational Health in the School of Public Health and Health Services. Thank you for joining us, Dr. Patierno.
It's a pleasure.
George Washington University is in the heart of D.C. How have you, as a Cancer Center Director, tackled the issue of disparities?
Well, Washington, D.C. is, as I think most people know, a majority-minority city. And because of the issue of cancer disparities and the large proportion of African Americans and a very rapidly growing group of Hispanics, we have some of the worst cancer statistics in the country. I sometimes refer to Washington, D.C. as a cancer disaster area. We are an acute microcosm of the national burden, of the unequal burden of cancer. When we started in 2003, when I became the director of the Cancer Institute in 2003, one of the first things that we did to better engage the community is that we helped found something that was then called the DC Cancer Coalition. The coalition was charged with actually writing the first cancer control plan for the District of Columbia, and it was a group of volunteer stakeholders from all around the city that came together to write a cancer plan, and then, of course, start the process of implementing the cancer plan. So the first thing that we helped do was create a coalition of stakeholders that was citywide to begin to address the issue of cancer disparities, not just in one medical center, but across the entire city. So I think this is a remarkable effort from a lot of different hospitals, cancer centers, and community-based advocacy organizations. At the Cancer Institute, the GW Cancer Institute, we started with opening a division of cancer education and outreach, and I think in the process of engaging this question of disparities, we actually wrote into the mission statement of our Cancer Institute the elimination of cancer disparities in metropolitan Washington. So that kind of suffuses all of the work that we do, from research to clinical activity to outreach and education. It very much engages cancer disparities from a lot of different directions. So we opened a division of cancer education and outreach. We created something called a community-by-community cancer control campaign, which for us meant we were going to systematically work through the wards and the neighborhood groups areas of Washington, D.C. with an army of outreach specialists. So we started with 4 full-time cancer outreach specialists. We actually created a new job title, and these outreach specialists were deployed out into the community to begin educational interventions, to begin talking with every group that we could talk to. We created a congregational, a workplace, and a neighborhood cancer wellness initiative, and sent our outreach workers into those particular areas where we developed a network of over 50 churches, a large number of barbershops and beauty salons, fraternal organizations, basically every area neighborhood organization that you can think of. And that started the process of building trust and raising awareness. We also operate the only mobile mammography program in the Washington area, which allows us in the area of breast cancer prevention to actually bring mammography into the most underserved areas of Washington, D.C. Simultaneously with that, we opened a division of cancer prevention and control, where we began the process of studying the demographics of cancer, and in Washington, D.C., where we were actually tracking cancer incidents neighborhood by neighborhood, so we could begin to understand where the hot spots are. We started a program called Cancer Mapping for Resource Targeting, and that allowed us then to know where we needed to send our teams in to do educational interventions, raise awareness about the importance of early detection, build trust in the community, and encourage folks to engage in healthy lifestyles that would decrease their cancer burden.
Can you describe the District of Columbia citywide Patient Navigation Research Program and your role in it?
Sure. In 2004 or early 2005, the National Cancer Institute issued an RFA to study patient navigation and its efficacy in reducing cancer disparities. It was very much focused on studying whether patient navigation could have an impact on two endpoints, whether it could reduce the time between suspicious finding and diagnostic resolution, and between diagnosis and the onset of treatment. Patient navigation is a concept, a huge effort that's now nationwide to create a new tier of healthcare workers whose job it is to help people overcome barriers to accessing healthcare. And it was the concept of patient navigation originated in Harlem, New York, with my colleague and friend Harold Freeman. But in Washington, D.C., we picked up on patient navigation very early, and so we applied for this grant from the NCI, and we became one of 9 centers around the country to study patient navigation, 8 funded by the NCI and 1 funded by the American Cancer Society. Our program is unique because in order to do this study, we had to bring the entire city together. We had to get other cancer centers and hospitals, which normally compete with each other, to actually cooperate with one another. And we succeeded in bringing an entire team together. It includes 5 hospitals in Washington, D.C., and 3 other community organizations, 1 central IRB, because this is actually a study that requires consenting patients, with sub-IRBs at all the other sites. And we started the process. Our PNRP program focuses on breast cancer, and we started the process of offering this service of patient navigation, but in the context of a research program where we were testing its efficacy. So we've been at it for 5 years. The data on the actual intervention is just going to come available this November for the first time in 5 years. I'm very proud to say that our coalition enrolled more patients into the program, more breast cancer patients into the program than any of the other sites around the country. So I get to brag a little bit on that. But 2 very important concepts emerged from our study. One is that in its original iteration, patient navigation started at suspicious finding and ended at the beginning of treatment. We learned over these 5 years that the barriers that affect access to treatment also affect access to screening and access to services after treatment is over. So we created a concept which is now known certainly regionally and nationally as longitudinal patient navigation, which is patient navigation from across the full continuum of cancer health care, from screening and early detection all the way to the survivorship period after the transition from active care. The other concept that came out that I think is still unique to Washington, D.C. is something we call network navigation, which is creating a seamless program that's citywide that allows us to pick up patients at community organizations, pick them up at screening sites, and actually create a seamless network of navigators and navigation for patients so that they can get access to their care anywhere in the city under this program. That concept of network navigation caught on with the District of Columbia and the DC Cancer Consortium, that is related to the DC Department of Health just recently gave us a $4.4 million grant to continue that program, not in the context of research, but in the context of offering a broader patient navigation program that's citywide.
You co-chaired an AACR think tank and a previous conference on the science of cancer health disparities in racial and ethnic minorities. What, in your estimation, are the biggest challenges to overcoming cancer health disparities?
I think one of the biggest challenges is being able to translate research, which, for example, the NCI would call the discovery of new information, being able to translate it to the community. In my view of cancer and cancer care begins and ends in the community. It starts in the community in the context of education and prevention, healthy lifestyles, patient navigation, screening for early detection. I affectionately refer to the community as the trench. Across the continuum of research, the trench should translate to the bench, where we're able to actually conduct, translational research that helps us with treatment and discovery. It needs to translate then to the bedside, but then after the bedside, it has to come back to the community in order to complete that whole circle and that whole cycle. I think that's one of our biggest blocks, is being able to translate discovery back to the community. And I think in cancer disparities, that is also one of our biggest challenges. We need to be able to translate the information, for example, that we gain in a study like the Patient Navigation Research Program. We need to be able to put that information to work back in the community, and that can only be done by engaging community outreach in a very effective fashion, by building trust in the communities and overcoming sometimes decades of fear and mistrust. So we need to engage disparities at the community level, but we also need, in parallel with that, systemic change. Mm-hmm. And systemic change has to start occurring at the highest levels of society, including policy. And so we do need to engage healthcare policy in a proactive way that makes sure that, that all of the gaps, for example, in cancer healthcare that exacerbate health disparities in the cancer arena are closed.
And what do you see, finally, as some of the solutions on the horizon? I think
probably the biggest solution on the horizon is not necessarily an end solution, but it's the huge awareness of the issue of cancer disparities, of how pervasive it is, of how critical it is for us to address these gaps, so that as our technology is racing forward, and as cancer research is racing forward, and we're making new discoveries with very high technology, we have to be aware that that technology could sometimes outpace our ability to implement it at the social level, at the level of people and communities, and has the potential to widen the gap of disparities. So by raising awareness, by conferences like this, by the AACR's conference on disparities, more and more people are becoming keenly aware of the magnitude and pervasiveness of the problem, and that, in the long run, is what is going to change things the most. What we learn, though, does, again, have to be translated to the community. It can't just stop in the lab. It can't just stop in the epidemiologist's office. That information has to get back in a way that actually changes the community, that changes people. At the end of the day, cancer is an individual disease, and sometimes we have to remember that we're in the business of saving one life at a time. So that information has got to translate back to the community. It also has to translate to the highest levels of society, to our policymakers, both our local, state, regional, and federal policymakers, so that we can catalyze systemic change, that some of these loopholes, some of these gaps that create these disparities can be closed and can be closed permanently.
Dr. Patierno, thank you so much.
Thank you.